Okay, so today we are going to discuss acute pancreatitis. A 45-year-old male diagnosed and managed for acute pancreatitis 2 weeks ago now presents with the tachycardia, tachypnea, and short of breath. And a 65-year-old man is admitted with a gradual onset of central epigastric pain radiating to his back. On examination, he has a regular pulse, 97 BP, 95-78 temperature, 37.3, a board-like rigid abdomen, and extensive ecchymosis over his flank bilaterally. What are your differential acute relapsing pancreatitis, acute cholecystitis, ascending cholangitis, and pancreatic pseudocyst? So these are the differentials. It can be relapsing, it can be acute cholecystitis, ascending cholangitis, cholecystitis simple, pancreatic pseudocyst, and it can be perforatic pseudocyst, peptic ulcer disease, or yeah. Definition of acute pancreatitis: this is an acute inflammatory process of pancreas that may involve peripancreatic tissue or remote organs. Peripancreatic tissue or remote organs, and acute inflammatory process of the pancreas. Acute inflammatory process of the pancreas uh, that may involve peripancreatic tissue or remote organs. The patient is tachypneic by abdominal pain, pressure by pseudocyst ARDS. Acute respiratory distress syndrome can cause tachypnea. The pseudocyst can put a pressure on the lungs, and abdominal pain can also. What are the scoring systems available for pancreatitis? So Glasgow scoring, the mnemonic is pancreas SS severity. So P stands for partial pressure of oxygen less than 8 kilopascal, normally is 10 to 13, age is 55, N is for neutrophils or WBC count greater than 15,000, calcium less than 2 millimole after 48 hours. Renal R is for renal urea greater than 16 millimole, normal is 2.5 to 6.7. Enzymes LDH should be greater than 600 after 48 hours. Albumin is less than 32 gram per liter after 48 hours. And sugar glucose greater than 10 millimole means hyperglycemia. At least 3 of the above will suggest that it's a severe episode and you should admit the patient in intensive therapy unit. So I think it's pretty straightforward and the mnemonic is pretty good. You can remember this. Ransom criteria. Assess mortality, estimates mortality of patients with pancreatitis based on initial and 48-hour lab. So if the patient comes to you, then do scoring according to Ransom criteria, and then do scoring according to Ransom criteria after 48 hours. So this will give you the severity of the pancreatitis. So at the time of hospital admission, you can do age, WBC, glucose, AST greater than 250, LDH greater than 350, international union per liter, glucose should be greater than 11. In milligram per deciliter, it's greater than 200. So WBC greater than 16,000, age greater than 5. So this is at the time of hospital admission. After 48 hours, you should eat something else like hematocrit drops by 10% or greater, fluid sequestration greater than 6 liter, calcium less than 2 millimole per liter or less than 8 milligram per deciliter, partial pressure of O2 less than 60 millimeter of Hg, and blood urea nitrogen rises more than 1.98 millimole per liter, greater than 5 milligram per deciliter after IV flow hydration. And base deficit greater than 4 millimole per liter. So this will gives you the severity. So prognosis implication of Ransom criteria: 0 to 2 points, mortality is 1%, 3 to 4 is 16%, 5 to 6 40%, and 7 to 11 points mortality will be 100%. So Apache 2 score acute physiological assessment and chronic health evaluation. This is another score used for severity of pancreatitis, and there is another the gold standard and best, which is Balthazar CT scoring system grading of pancreatitis, which also called CT high scoring. So A class is normal pancreas, B is enlargement of the pancreas, which scores 1, inflammatory change in pancreas and peripancreatic fat, and ill-defined single peripancreatic fluid collection, which is D, and E will be 2 or more poorly defined peripancreatic fluid collections. CT used to judge severity or complication, done after 4 to 5 days after admission, presentation in mild moderate cases. CT find, okay, so in pancreatitis you never do CT for like normal pancreatitis or uncomplicated pancreatitis. For CT the indication is complications, so you go for CT when there is complications, so to score it according to CT Sayab Baltazar. I think this scoring they haven't described it very well here. I will share it in the channel. CT findings in acute pancreatitis: edema, fat stranding, collection, necrosis, abscess, and pseudocyst. These can be shown on the CT. What is the pathophysiology of hypocalcemia in acute pancreatitis? So, in the early phase, autodigestion of mesenteric fat by pancreatic enzymes and release of free fatty acids. These free fatty acids will chelate or combine and sequester calcium, which form the calcium salts, transient hypoparathyroidism, and hypomagnesemia. Later stages due to complication by sepsis, which will lead to increased circulating catecholamines, which will cause a shift of circulating calcium into the intracellular compartment, leading to relative hypocalcemia. Hypoalbuminemia also causes hypocalcemia. Okay, so you can divide the hypocalcemia caused by acute pancreatitis into two phases: the acute phase and the chronic phase. In acute phase, it is due to the saponification, which is the pancreatic enzymes will act on the peripancreatic fat or nearby mesenteric fat, so they will convert the fat into fatty acid, free fatty acid, which will sequester or chelate the calcium and will form the calcium salts. So this will cause transient hypocalcemia, and later on, due to sepsis and hypoalbuminemia, there will be shift of extracellular calcium into towards intracellular compartment, and so it can lead to hypocalcemia in the long term. What is the pathophysiology of hyperglycemia? So pancreatic enzyme destroy B cells of islets of Langerhans and decrease insulin stress response by releasing counter-regulatory hormones, cortisol, glucagon, which have anti-insulin effect. So listen, they can also ask you the question that in chronic pancreatitis, here we are discussing acute pancreatitis, but in chronic pancreatitis, what will be the first function lost, either endocrine function or exocrine function? So remember, the first function lost in chronic pancreatitis is exocrine function. Why? Because the exocrine cells are on the outer side, and the endocrine cells, the islets of Langerhans, they are on the inside or in the center. So first exocrine function will be lost, and second Langerhans cell. So when the beta cells are destroyed by the pancreatic enzyme, so it will decrease insulin and also a stress response because it's an inflammatory condition. Even pancreatitis can kill you. It's a very severe condition and very serious condition. So the stress response will release counter-regulatory hormones like cortisol, glucagon, and catecholamines, which can lead into anti-insulin effect. So it can cause hyperglycemia. What are the complications of acute pancreatitis? So it can be local, it can be hematological, it can be metabolic. So local can be pseudocyst, abscess, ascites, necrotizing pancreatitis, fat necrosis, phlegm thrombosis, but it is in the long term. Phlegm. GI will be ileus, bleed, or renal acute renal failure. Hematological DIC, hepatobiliary jaundice, portal vein thrombosis, strictures, systemic hypovolemic shock, hemorrhagic pancreatitis, hypocalcemia, and SIRS syndrome of inappropriate response syndrome, multi-organ dysfunction. I have seen personally many patients, like 5-6 cases, which are died because of acute pancreatitis. Acute pancreatitis is a very severe condition when you take it easy, it can kill the patient. Patient will abruptly go into short of breath, will go into sepsis, multi-organ dysfunction, AKI, and it will kill the patients. I have seen personally. Metabolic hypocalcemia, hypoalbuminemia, hypoxemia, and hypomagnesemia, and hypercalcemia, respiratory ARDS, pleural effusions, and death. Late complications, cirrhosis, splenic vein thrombosis. Causes of acute pancreatitis is eye gets smashed. Idiopathic gallbladder, so most common is gallbladder, and second most common is ethanol alcoholism, and can be trauma. In children, trauma is the most common cause. Steroids, mumps, malignancies, autoimmune, scorpion sting, hyperparathyroidism, hypercalcemia, ERCP, drugs, thiazide, sulfonide, urea, cyclophosphamide. Is serum amylase important in scoring system? No. Causes of normal amylase in pancreatitis. Too early or too late. Too early when there is the amylase is not fully developed in the blood. The concentration of amylase is not fully developed in the blood, and late when the exocrine function is lost, or in acute pancreatitis specifically, if you say it's in chronic pancreatitis, I said that function is lost. In acute pancreatitis, very late the amylase is cleared of the serum. It has a short half-life. Why amylase is not reliable? Returns back to normal levels in 48 hours after the onset of the attack. Does not correlate with the severity of pancreatitis. Non-specific for pancreatitis. Which enzymes to check apart from amylase and lipase? LDH, lactate dehydrogenase. You can also do serum CRPs. How will you manage nutrition in patients with acute pancreatitis? First, refer to nutritionist team. TPN is usually needed in severe cases, but not in every cases. In mild cases, even there is no need of NBM status. You can just pass the NG nasojejunal to bypass the pancreas. So to rest the pancreas. Recently, there is a growing trend towards early nutrition of enteral feeding with nasojejunal tube. Yes. Considering pre-morbid nutritional status, current nutritional needs, estimated return to normal feeding. So you do enteral feeding because it will stop the translocation of bacteria into the systemic circulation. How will you treat splenic vein thrombosis? Give patient low molecular weight heparin, multidisciplinary approach that may include gastroenterologist, hepatologist, a hematologist, and intervention radiologist, and a surgeon. No low molecular weight heparin if concurrent hemorrhagic pancreatitis. I will go for intervention radiology for coiling or removal of the thrombus. What are the complications of coiling? Injury to adjacent structures, failure, hemorrhage, and infection. Splenic vein is not a small vein. It can bleed to death. We have seen in open surgery. It can kill the patient within minutes. Functions of the pancreas: endocrine cells of islets of Langerhans, alpha cells glucagon, beta cells secretes insulin, delta cells somatostatin, polypeptide cells, pancreatic polypeptide, PP cells. Exocrine pancreatic enzymes: digestion of fat, carbohydrates, proteins. So enterokinases, trypsinogen, entotrypsin, lipase, lipase in fats, amylase in glucose, enterokinases, and trypsinogen, trypsin, and amino acids and polypeptides. What is the pathogenesis of acute pancreatitis? So duct obstruction, a reflux of bile into the pancreatic ducts causing injury, increased intraductal pressure may damage pancreatic acini, lead to leakage of pancreatic enzyme with further damage to pancreas. Direct acinar damage due to viruses, bacteria, drugs, or trauma. Protease release causes widespread destruction of pancreas and increased further enzyme release with consequent further damage. Lipase causes fat necrosis resulting in characteristic yellowish-white flecks on the pancreas mesentery and omentum, often with calcium deposition. Fat necrosis, elastase destroy blood vessels leading to hemorrhage within the pancreas and hemorrhagic exudate into the peritoneum. Hemorrhage extensive may lead to acute hemorrhagic pancreatitis. So this was the mechanism of pancreatitis. You can also check the diagram and the various factors described. Okay, So we can do another video for the rest of the questions. Yeah.